Good afternoon, folks. This is Kathy Barrett with Cornell's ProDairy program, and I want to welcome you to this Thursday's Dairy Update. This is a program that we put on about once a month to let folks know what's going on here on campus and in the industry, kind of give you an update for what's new in the dairy industry. So Cornell's ProDairy program and the New York Farm Viability Institute work together to put this webinar series together for you. So today we're excited because we have Dr. Tom Overton with Cornell University and Allison Kerwin, who's going to be sharing with you new dietary approaches to manage hypocalcemia in transition cows. They're going to get started in a minute, but I just wanted to tell you a couple of things. The first is that if you have questions as we go through this presentation, please feel free to put them in the chat box, and then I will at some point either interrupt Tom and Allison or wait till the end and we'll get to those questions. But please feel free to do that. We're going to run to about 1:15 and probably about 1:10 or so we'll stop for those questions. The other thing is I want to tell you that we are recording this presentation. So if you want to go back and hear something again, or if you have colleagues that you want to share it with, it'll be on the ProDairy website probably by tomorrow morning. We edit it and try to put them up as quickly as we can. So there's another opportunity to access this information. So with that, I'm going to go ahead and turn this over to Tom Overton. I think most all of you in this in the whole area of dairy nutrition know Tom, but he's a faculty member here at Cornell, does a tremendous amount of research in nutrition. He's also the ProDairy director. He's our director for ProDairy as well as for Cornell Cooperative Extension's agricultural programs. So Tom, can I let you pick the ball up from here?
Yes, Kathy, thank you very much. Good afternoon, everybody. Good morning, good evening, depending on where you are. Glad to be with you today and introduce Allison Kerwin. Allison is a PhD candidate in our program and had a hand in a bunch of the research that we're going to present here today. So, we're going to talk about hypocalcemia today. It's an area that I continue to be amazed at how much more we've learned in the last few years about calcium metabolism in the cow and approaches to not only identify but also to prevent hypocalcemia. If you asked me 10 years ago, if we and lots of others would be spending as much time as we have in this area, I would tell you that you're crazy. But it's been a fun area to be part of, and we're going to talk about some of our work and allude to some others here in the last few years. Okay. So we're going to jump right into it, and I think everybody's familiar. If we look at some data, these are actually data from Brittany Linos, did a PhD in our program, her PhD work, just looking at blood calcium concentrations in the transition period. And we see here that as they approach calving, or a cow approaches calving, these drop fairly precipitously with the onset of colostrogenesis and milk production. And of course, we want these calcium concentrations to rebound quickly after calving. So we really want to minimize the extent and duration, at least to a large extent, of this blood calcium drop. So the $64,000 question, at least in the Northeast, has been, and in lots of other places, has been, do we need to worry about subclinical hypocalcemia if milk fever rates are low? I think, frankly, clinical milk fever is a thing of the past on many dairies. We have lots of farms that maintain clinical milk fever rates of 1 or 2%, maybe even 3% or less. Yet we now know that we have lots of cows, even on many of those farms, that would be categorized as subclinically hypocalcemic. And depending on which data sets you look at, it can range anywhere from 40 to 80% of cows in the hours and days after calving. So we also know a lot about some of the risks here, and much of this information comes from some epidemiological type work, again, done with larger numbers of cows in most but not all cases. But we do know that subclinical hypocalcemia, we can associate that with impaired health, whether it's metritis, DAs, mastitis, subclinical ketosis, immune function, poor milk production, poor reproductive performance, and again, Cachetta et al. Recently, characterized as kind of a chronic subclinical hypocalcemia, referring to cows that not only became hypocalcemic but kind of stayed there through the first 3 days or so after calving and showed increased disease frequency and increased time to pregnancy. we now know that, and we also, I think it's important to recognize that the risk may actually depend on the timing of the blood sampling. There are a couple studies here, the Chamberlain work out of Missouri, and then Raf Neves's PhD conducted with Jess McCart here at Cornell, actually found no association of subclinical hypocalcemia with retained placental metritis. And then further, Raf found that multiparous cows with lower calcium concentrations in the first 12 hours of calving actually made more milk. Okay, so some drop of blood calcium, as long as they don't go clinical hypocalcemic, may not be the worst thing in the world, maybe associated with more milk production, but it's those cows that maybe after don't recover as well that we really should be concerned about. So I think it's important to just quickly refresh our memory relative to how blood calcium is regulated. Of course, here in the middle, we have this drop or decrease in blood calcium levels. That triggers the parathyroid gland to secrete parathyroid hormone, or PTH. PTH does a couple different things. The one that all of us were taught in Dairy 101 was that PTH goes to bone and causes the release of calcium from bone and likely phosphorus as well. And that then, that release of calcium into the bloodstream increases blood calcium. So the cow resorbs calcium from bone in order to meet that need. The other thing that PTH does, though, it goes to the kidney, activates vitamin D, alters calcium excretion. The active vitamin D increases calcium absorption from the intestine. And I think that's almost been a bit of the forgotten route here. And intestinal calcium absorption, we certainly think is also an important route by which the cow recovers or maintains her blood calcium. So we have sort of a bimodal way that the cow can really do this. So how do we deal with it, right? So what are potential strategies to improve calcium status, and then postpartum health, performance, and repro? You know, we can think about, well, geez, do we administer calcium at calving or at or after calving, and do it as a treatment or prophylaxis, either by IV or sub-Q or bolus or other oral form? And secondly here, and we're going to talk about these in this order, you know, we can also talk about ration formulation strategies for that prepartum or close-up diet, okay? So again, when you think about if we just first talk about this post-calving calcium treatment or prophylaxis, we think about IV calcium. You know, of course, IV calcium gives a very rapid supply of available calcium. We certainly would concur with the veterinary community that that's appropriate treatment for clinical milk fever. Neither Allison nor I are veterinarians, but again, I think our colleagues would concur with this, and I know Jess certainly would concur with this that you know, really, if you don't have cows with clinical signs, IV calcium is probably unnecessary. And I can actually, I'm going to show you some data in a minute that shows that in some cases it might be detrimental. Oral calcium boluses or drenches, you know, obviously for that recumbent cow, for that true milk fever cow, it's not going to provide calcium quickly enough. But it certainly does release calcium salts or other compounds more slowly, and certainly you can make an argument on cases where a farm determines that a cow actually does need some calcium treatment. It might be appropriate in that case, and we'll talk more about that. And then, of course, subcutaneous calcium is sort of intermediate to the above two options in terms of rate of release and things like that. This was an interesting study. This was done in California by Cedric Blanc and Noelle da Silva del Rio's group at University of California down in Tulare. And what they did is they had cows that they categorized as being subclinical hypocalcemic post-calving. And they did three different things with them. They either did nothing with them. So the control line is in the solid black line here in the middle. So they had and you see the blood calcium concentrations, you know, after they made a treatment decision. In this case, it was no treatment. Right above that, you see the line for the cows that were given 2 calcium boluses 12 hours apart, which would be according to some of the recommendations that are out there. And you do see some elevation or slight elevation here of blood calcium level in the cows given the boluses. But the really interesting thing here is in these cows that were subclinical hypocalcemic, then gave IV calcium, you see this immediate spike in blood calcium, but then a rapid decrease in blood calcium, and that line actually goes below the others. So those cows actually became hypocalcemic, you know, after being hyper, almost calcemic in that case. So really interesting. And I think, I've had some field experiences where we've had herds that I think now I think I know, had gotten too aggressive with IV calcium in fresh cows and actually probably induced more problems with hypocalcemia than they fixed, simply because of this rebound hypocalcemia. And I think what's going on there, you remember the cow's calcium metabolism is homeostatically regulated. That system senses all of a sudden that there's lots of calcium in the system, and so it's going to start to turn those mechanisms off. Okay, so and we want the cow to work biologically as she should. There's now been several studies done with calcium boluses, and I'm just going to summarize them on this slide. One done at the University of Wisconsin, another one done out of Florida, and then another one done here at Cornell, led by Jess McCart's group, in collaboration with some others, anyway, including our group. And I think the bottom line for me on boluses is typically, none of these studies really show any across the board or overall type responses. Where you start to see responses is when you begin to subdivide or subgroup cows into higher risk cows, whether they're lame, they're old at calving, sometimes really older cows. And there's even some data from these data sets that suggest that it might even be detrimental for certain categories of cows as well. So we really question some of the blanket treatment approaches that are out there. Not only are they costly, but they're also probably not effective for a fair number of the cows that are being treated. So we tend to push herds more toward targeted types of approaches to giving boluses rather than blanket treatment approaches. A couple studies here that actually have looked at sub-Q calcium. This was done at the University of Guelph. This is about 1,000 cows on 7 dairies. These cows, again, did not have clinical milk fever. They gave sub-Q calcium immediately post-calving, and again at 12 to 24 hours post-calving. You see the treatments here, or the treatment here. Basically their results were a whole lot of not much. Just a very slight increase in calcium. Maybe a very slight reduction in terms of the risk of subsequent calcium treatment, but as you can see there, no effect on disease, culling, production, or reproduction. So, again, suggesting that perhaps calcium sub-Q may make some folks feel good, but at least as blanket approaches or prophylactic approaches, not really doing a whole lot. Okay. And then finally, this study done in Iran, about 400 cows on a commercial dairy. You see, again, either no sub-Q infusion of calcium or 3 different treatments here with various amounts and et cetera relative to sub-Q calcium. Kind of bottom line here is also not a whole lot. Increased blood calcium during week 1, maybe for cows giving calcium, a little bit more intake in the first 24 hours post-calving, and maybe a little greater risk for metritis or uterine disease for controls. But again, not a whole lot here to get too excited about. So, our bottom line at this, at this point, and this is kind of where it's been, is that we really need, if we're really going to do a good job with postpartum hypocalcemia, we got to manage the prepartum diet. And, there's really 2 possible strategies out there. One is, and the one that's received, I would say, the most research attention and by far the most field experience, is to manipulate the dietary cation anion difference, or DCAD. And in that strategy, we minimize or avoid high potassium forages, which generally steers us away from legumes or forages that have seen a lot of manure. And then we supplement anions in the form of chloride or sulfur-containing supplements. The second approach, which isn't necessarily a new approach, but it's gotten some renewed attention anyway, has been to actualize a low calcium diet through use of a binder of calcium in the diet to decrease absorption. And so I'll review some data from our group that has looked at this here quite recently. So just a reminder on DCAD, again, this is, we've known the first papers on DCAD or this concept came out in the 70s. First application, to my knowledge, in the 80s, and lots of work on it since then, and lots of field experience. But the bottom line with DCAD is we try to minimize or control cations in the diet, like sodium, potassium. We potentially supplement or anions like chloride and sulfur. I guess I got some formatting stuff here, but bottom line is by slightly shifting the acid-base balance in the cow, we do several things relative to calcium metabolism. And so there's data to back all three of these impacts on calcium metabolism in terms of tissues responding better to PTH, that make some creation of a calcium flux or demand through excretion, and perhaps, you know, some actual direct stimulation of calcium absorption through these alterations in acid-base balance. You know, bottom line, regardless of mechanism, is DCAD. We know it sets the tissues of the cow up better to respond to that calcium demand. So our major strategies have been, you know, largely, you know, focusing, you know, on either feeding low potassium feeds and also controlling sodium to the close-up cows. So you know, typically, you know, that's only working on the one side of the equation. And frankly, if we do that, if we get potassium levels under 1.3 in that close-up diet, and we supplement some magnesium, you see below, and I tend to favor calcium supplementation, we can do a really nice job preventing clinical milk fever, but we probably don't control the subclinical hypocalcemia very well. We can also take a middle of the road approach and take the edge off here and feed low potassium forages with a partial use of anions in the diet, maybe run the DCAD down to around 0. Again, take the edge off a bit, you know, and maybe get some better responses. And then we can certainly go in the more fully acidified route here, the third option, where we're going to feed our low potassium forages, but then come in with more of a full use of anionic supplement in the close-up diet, run the calculated DCAD down to -10 to -15, give or take. Urine pH is 5.5 to 6, and that's how, again, we monitor implementation of anionic diets. And, you know, those are a little more aggressive urine pH recommendations than maybe what folks have traditionally thrown out there. But, you know, as I'll show you, our data and in addition to that, our field experience, you know, supports that we can have some nice results with being a little more aggressive on acidification. So I'm going to take you through some work that Brittany Lino did as part of her PhD. We'll cruise through it fairly quickly, but we really tested those 3 different strategies here in a study that we did. Had about 30 cows entering second lactation or greater per treatment. We fed them we had them on a low potassium control before they went on to treatment, and then the treatments were a low potassium control, a medium DCAD, and a low DCAD until calving, and then put them on the lactating diet thereafter. Just show you the diets so you understand generally how we put our diets together. We had a BMR corn silage, wheat straw base. These are pounds of dry matter as formulated. The cows actually ate very similar amounts of the 3 diets, as you'll see, and ate actually a little bit more than this from an intake standpoint. So the numbers would be just slightly higher if I were to break out actual consumption here. But BMR corn silage, wheat straw base, no haylage, and then a grain mix from there with our proteins and non-forage fiber. And then you see, getting to the bottom, we use one of the commercial supplements, the anionic supplements that are out there, had 0 pounds in the control, about 0.6 pounds of that in the medium, and then about 1.2 pounds in the low DCAD treatment. Okay, and everything else is formulated to be the same across treatments. You look at our analyzed composition. I'm showing you this in part just to give you a sense for where we like to run these diets, and we're pretty happy with how these came out. About 46% dry matter, about 44% NDF across the 3 dry or close-up dry treatments, 16 to 17% starch, calcium about 1.5 across all 3 treatments. So we supplement the same amount of calcium across the board. Magnesium here at between 0.45 and 0.5% of the diet, potassium under 1.3, and then by design, sulfur and chloride increased as we added more of the anionic supplement, and DCAD went down. And our predicted MPs here at the bottom, metabolizable proteins, and again, based on actual intakes, we were up in the 1,400-ish gram range. Show you our urine pHs here. Again, the controls, you know, urine pH 8.2, 8.3, very characteristic of cows not fed anions. The middle treatment here was running just under 8. And then the low, we were down, you know, again, fairly tight here and in the upper 5s, you know, for the last couple weeks here before calving. Okay, so we achieved our goals to get those cows down into that, you know, just under 6 range. We did have overall effects on blood calcium, so we improved blood calcium overall linearly. We did have a trend for a treatment by parity interactions such that the older cows really responded well to the more negative DCAD. And I think that matches or mirrors what we see out in the field. In terms of intakes, these are in kilos. We were basically had very, very similar intakes here across the 3 treatments. We were 14 to 15 kilos. So, you're in that 30, 31 pound range in these cows. We did have a quadratic effect, but again, I think you look at the means and they're pretty close together. They're all within about a pound of each other. Okay. Post calving, we did have a trend anyway, or significant, depending on how you looked at it, in terms of increased intake linearly as we went from the control to the medium to the low. So we picked up, not quite 1.5 kilos. So that translates into, 3 pounds or so more intake in the fresh period, which again is good. Okay. We like more intake in fresh cows. That also translated to more milk. We had about 3 kilos more milk here also in these fresh cows during that post-calving period. So we picked up 6 to 7 pounds of milk for cows fed as we went from the control to the medium to the low. So, again, nice responses here, and there's lots of other studies with DCAD as well. And some certainly show performance responses, some don't, but that's kind of normal in the literature, is that you are going to see some variation among the study results. Okay. So just some summary considerations here for DCAD. We want to certainly make sure we're accounting for our macrominerals and forages, wet chemistry, consistency in forage and feeds and mixing is key. We got to prevent sorting in the diet. So managing particle size and moisture is important. We really favor the commercial products best from a palatability standpoint. The old salts, we're kind of notorious for poor palatability. I don't run into those as much here in the Northeast as I do in other parts of the country and the world, because they are still out there in some other areas. I generally see most of the commercial products here in the Northeast. I think that's the way to go. Magnesium supplementation is important. And again, you use urine pH monitoring to gauge implementation. 6 to 7 is a general recommendation, and with excellent management, we get urine pHs down even a little bit lower, and we think we have better results. Quick comment on variation. I get asked about urine pH variation all the time. We've kind of favoring actually the approach where we actually calculate the CV if you're doing urine pHs. So you do 12 to 15 calories of urine pHs as long as they've been in the diet for about a week. And when herds are doing a really good job with their feeding management, they get that CV, which is again the standard deviation divided by the mean, under about 8%. Okay, and anything over 10% is a flag for me, and we then wonder about sorting behavior and things like that in those cows and herds.
Okay, so Tom, could I interrupt you here just for a question?
You're the boss.
Okay, so
actually I am, but go ahead with the question.
So I'm going to read the question because some people are just listening to this as they're driving or whatever. So one question for you, Tom, is, hi, don't you think intervening directly into the cow's system by using low DCAD diets will cause stress, which may put them all at even greater risk of developing metabolic diseases, NEB, etc., than when you take diets that are naturally low in calcium, high corn, straw, soybean meal, etc.?
Yeah, so we're going to talk about low calcium feeding right now. So we'll get into that. I think the vast majority of the data that I'm aware of, and also the field experience with DCAD and managing DCAD, is that they do not result in additional stress or more risk for metabolic disorders and things like that. I think where in the early days of DCAD, when people were using more of the salts, the things like calcium chloride, which is the main ingredient in ice melter, for example, and if you ever tasted that, it's caustic on your tongue. And I think where people got in trouble early on with those sources was they would lose intake in those pre-fresh cows. And if you lose intake in those cows, or meaningful amounts of intake, yes, you are more at risk for metabolic disorders. But I don't think it was the salts. It wasn't the salts' effects on metabolism. It was the salts' effects on intake in those cases. Again, I showed you data just now with fairly aggressive anionic supplementation, where we held intakes essentially the same across the 3 treatments and had very good results. I don't have this paper. The paper is now published now. You can go to the Journal of Dairy Science paper and you'll see we had very low incidence of metabolic issues on cows on that study. Okay, but good question, and we'll get into low calcium feeding now. Okay, so low calcium feeding is sort of a back to the future kind of approach. you know, the notion that you can feed calcium below requirements and that you can then stimulate the cow's system in terms of calcium homeostasis prior to calving, you know, is not a new one. I think the thing that Jesse Goff and others, Jesse's one of the gurus here in this area, is always kind of said, and is that you got to get calcium less to about 20 grams per day absorbed, and in general with the feeds that we work with, that's very difficult to do. Okay, so you know, you probably can eliminate, again, clinical issues. You probably don't eliminate the subclinical stuff. And so, you know, the way maybe to actualize this is to feed perhaps compounds that bind calcium in the diet, and then you can feed those. If you decrease their absorption, you can then create a diet that is functionally deficient in calcium. Okay, and that's been kind of the thought here. So there's been work on and research and field experience on a calcium binder for, you know, not quite 20, or probably about 20 years out there, mostly in Europe. The last few years in Canada, and it's now coming into the U.S. market. Just showing you some data here from some studies done overseas that basically show feeding a calcium binder actually improves blood calcium status at calving. So you see fairly pronounced improvements here in blood calcium, you know, across these two different studies when cows fed the binder. So this is it. This is it's actually a synthetic zeolite A. It's a sodium aluminum silicate. It's capable of binding calcium, phos, and mag, and again, it's been shown to have effects on calcium status. Okay. So this is what we did. Again, this was done here. We started this study about a year ago, and finished it up, you know, in the summertime into the fall, and data analysis from there. I say we, it's really Allison. I think if any of you know how things really work, and I'm chief cheerleader. So anyways, so what we did is we wanted to look at feeding the calcium binder to multiparous Holstein cows pre-calving, look at mineral status, intakes, performance, oxidative status in these cows. We enrolled 60 multiparous Holstein cows. You see what we did with cow removal here. You know, so again, a mixture of second and third lactation cows. We enrolled these cows 28 days before expected calving, and then put them on a treatment at 21 days before expected calving. Diets were, I don't have the diet ingredient composition for you, at least not here, but very similar to how it's kind of like the diets you've seen before, with about 40% corn silage on a dry matter basis, 34% wheat straw, and 27% grain. These were low potassium controls, non-DCAD formulated. And then you see and then with the experimental cows basically got the controlled diet with essentially about 500 grams or targeting 500 grams per day per cow of this calcium binder. And you see the trade name for the binder, Excellent, and the distributor there, you know, and the manufacturer there at the bottom. And of course, after calving, all cows are fed the same post-calving diet. I'm going to go through all the detail on what we collected from a data standpoint. Let's just say Allison took lots of blood samples and measured a whole bunch of things in them related to the mineral side, and then also some things related to oxidative stress or status, some things relative to rumination intakes, body weights, milk composition, did some colostrum, health outcomes, and repro performance by 150 days of milk. Lots of stats, not going to go through that at all. You guys can study that again, hit rewind a few times if you want to, but lots of stats here done and done appropriately. Look at chemical composition of the diets, pretty similar to what I just showed you before. NDFs in this case about 46, starches between 16 to 17. Calcium, again, we had very little notable supplemental calcium in these diets. Run at about 0.6 or between 0.6 and 0.7, again, as analyzed. Phos was just under 0.4, magnesium about 0.42, potassium just over 1.1%, sulfur down at 0.2425. Sodium, again, was increasing the experiment against sodium aluminum silicate, so it's going to put some sodium in there. And chloride was the same too across the two prepartum treatments. So again, you see the fresh diet there. All right, let's get into the results here. So pretty large effects here on blood calcium in these cows. The next several graphs are formatted the same way. You've got day relative to calving on the bottom, and again, 2 samples in the first 24 hours post calving, and then daily samples, and then going from there. And so you start seeing these cows fed the treatment. diet to have a little higher calcium levels even starting before calving, and then after calving that continued. So fairly large improvement here in blood calcium. Phosphorus was also decreased quite substantially in the treated cows, and there's certainly thought that's part of the mechanism here of action, but you see a large decrease here in blood phosphorus before calving, and then you see phosphorus does recover here after calving as these cows get going. Okay. Saw slight decreases in blood mag as well, and again, but those also recovered as cows got into lactation. If you look here at subclinical hypocalcemia prevalence, again, this is by day and this is by percent of cows. And you go those first two samples, in the first 24 hours post calving, we had 80–90% of the controls with subclinical hypocalcemia. That's not different than what we've seen in other studies, or some other studies anyway. And we dropped that down to only about 30% in the cows fed the treatment. And as you can see here, they recovered very, very quickly. The cows fed the treatment after calving. So, by day 3 anyway, there was essentially maybe one cow that still had maybe low calcium in the treated cows. Allison also came up with this way to look at kind of chronic subclinical hypocalcemia, and basically what this is she just said, okay, how many samples, blood samples were at or under 8.5 milligrams per deciliter in the first 3 days of milk, okay? And it ranges from cows that had no samples, under 8.5, so cows that maintain good calcium status throughout. You see that, about half the cows here of the cows fed the treatment did. I think probably only one cow here out of the controls did. And as you can see here, she had 30 to 40% of cows with either 3 or 4 samples under 8.5 through 3 days in milk, and essentially very few of the cows getting the treatment. Okay. I'm going to cruise through also our outcomes. Again, I'll show you the intakes and other parameters here. So here's prepartum intakes. Again, intake's pretty good overall, about 30 pounds of dry matter. We did see a trend anyway for a little bit lower dry matter intake in cows fed the treatment compared to the control. But again, fairly modest in terms of overall magnitude of response. A little bit lower body weight in those cows, a little bit less body condition in those cows as well, kind of matching up probably with the intakes. Post-calving, we had no significant effects on dry matter intake, calculated energy balance, body weights, body weight change, body condition score, a little treatment by week effect there on body score, but I think it was relatively small. Okay, just show you some graphs here, intakes in kilos. Again, you see that we did see some tail off here in intake, a little more pronounced here in cows fed the treatment. After calving, again, no significant effects here on dry matter intake for cows fed the treatment or the control. Milk composition, we did see no effect on overall milk yield, either weeks 1 to 4, 1 to 9 here in the study. Cows milked well in this study. We did have a treatment by week effect on milk fat, a little indication for maybe a little more milk fat in those cows fed the treatment. Actually, it happened a little bit actually not right at calving, but it was actually a little bit further out from calving where we saw the butter fat. No effect on, pretty much no effect on other components here, as you can see. Okay, a trend here for higher total solids content in cows fed the treatment. Milk yield, again, no overall effect on milk yield. Energy corrected milk yield, that's where the butter fat effect comes into play here just a little bit. Saw a little bit more, well, again, the overall treatment or treatment by week effects were not significant for energy corrected milk, but again, the lines do come apart. Again, the butter fat content driving that a little bit. And then colostrum, we had no significant effects on colostrum, either yield, IgG content, or IgG yield. You do see, something approaching a trend here for a little bit less colostrum yield for cows fed the treatment compared to the control. No effect on IgG concentration, and the net of those two is no effect on total IgG yield. Okay. Allison also looked at a bunch of oxidative stress parameters related to either antioxidant potential, reactive oxygen species, one of the, you have to ask the question, if it binds some of the macrominerals, does it bind trace minerals too? We decided to look at oxidatives, these kind of more functional outcome parameters, because if that was dramatically altered by the binder, we might see some effects here, and you can basically see we had no effect. So there's no effect here on oxidative metabolism, at least as far as we could tell through these blood-based parameters. We're going to health events here. Again, not a big enough study to really do justice here. Looking at health events, we'll let you just look down here. You see, again, some trends potentially for things like mastitis, DA. No effects beyond that. I'm sure there'll be questions come up on some of the calcium phosphamag treatment, maybe during the Q&A, and we'll let Allison jump in and talk about those a bit more. And then I think the last thing I'll show you here is just time to pregnancy. So this also was not quite a trend, although for a study of this size to pick up even anything close to that is interesting and certainly needs more a further look here. So if you look at the median days to pregnancy, mean day to pregnancy, you see about 70 days in the treated cows and 89 days in the control. Okay, so which 50% of the cows were pregnant. Sorry, Allison's nodding at me, making sure I don't butcher my epidemiology and survival analysis too badly. Julio Giordano would be jumping up and down right now. So anyways, so some relationships there I think are worth some further look. So just to give you an overall summary, and then we'll be glad to take some questions. I think the key point here and our learning here in the last 5 to 8 years for sure has been that management of subclinical hypocalcemia in post-calving cows is important for health, milk yield, and repro, even when we don't have clinical issues. Okay, don't let the lack of milk fever fool you in our herd, because there can still be opportunities to do better in terms of calcium metabolism. We have absolutely learned that here in the Northeast. Calcium treatment prophylaxis, I think, is beneficial only in selected high-risk subgroups of cows. And so, we really push herds to be more targeted with their treatment or prophylaxis if they're applying it at all. The blanket treatments certainly we don't generally see overall responses in health, production, and repro. I would say prepartum nutritional management is the only way to robustly improve subclinical hypocalcemia. And our options have been managing this dietary cation-anion difference through use of antibiotic supplements. Again, those have been tested through multiple trials, lots of studies over time, as well as field experience that show us we get better blood calcium along with responses relative to intake and performance. And certainly as an alternative to DCAD, again, you're not going to worry about DCAD at all with a low calcium or when you actualize this low calcium diet approach by use of a binder. So that's, on some level simplifies some things, certainly, from a variety of perspectives, that certainly in our hands and in other hands improves blood calcium. And, from our standpoint, those trends toward the positive effects on reproductive performance certainly justify more investigation there. So again, we appreciate you taking time out of your day to listen to us, and we'd be glad to take some questions. So thanks, Kathy.
Okay, great job, Tom. So folks, we do have a question in the chat box, a couple of questions. Also, with this size group, if you want to go ahead and unmute yourself and ask a question if you're more comfortable with that, or if you're just not in a place where you can stop and type, please feel free to do that. So Tom, the first question here that we have here is, what is the future of research into this topic? What are the kinds of things your group is looking at at the moment?
Yeah, so a great question. We are, I think we're still, again, some of these data are fairly hot off the press, and so, but we continue to be pretty interested there in this whole area. We actually don't have any studies going on exactly right now. We are certainly curious on, I think it would be worth looking at more deeply into the reproduction. I think the immune side, we know calcium is important from an immune function standpoint, and we're certainly interested there as well. And again, we've got a bunch of other stuff going on, but those are certainly some areas that need more work here on the calcium side. I think we did not in one study choose to compare the approaches, right? That's more work that certainly could be done relative to, let's look at a low DCAD scenario versus the low calcium. We felt like we had enough data on low potassium diets from multiple studies to really know how those perform in our hands, and we would have a good relevant comparison there.
Okay, so the next question, any explanation for more DAs from,
for the treatment cows.
Treatment cows. Okay.
Yep. So I'll take a first stab, and then Allison, if she wants to jump in too. That of course that was a trend, right? And not enough cows look at it. We did not. Some groups would dump those cows from data sets. I don't think that's necessarily the right thing to do in these cases. So we retained them in the data set. We actually went through and made, one of the things we do is we actually make our decisions on cows in the data set completely independent of treatment. So Alice and I sit and do that too. In this case, we did it together. I was totally blinded to treatment, and we went through and made decisions, and she was too. At least, well, maybe she wasn't as blind as I was totally blind, and we made decisions relative to what to do there, and that's just how it shook out. But certainly worth certainly a curiosity.
Yeah, I don't have too much to add to that. It's something that was interesting. And again, I mean, you look at the two treatments, and those cows, the experimental group really did have improved calcium. So I was actually surprised to see that there were 3 cows that came down with a DA. Those 3 cows, I know they also did end up getting ketosis as well. But again, I really don't have an explanation as to why we had 3 cows that had a DA in the treatment group.
So Kathy, can I open the chat box on my screen here?
Yeah, see if it's coming up. They were sent to everyone, so maybe you can see it on your screen so that we.
How do I?
Do you click the more?
More. Okay.
Get it?
By the way,
I have a question. How do I access the chat box? I'm not seeing that on my screen.
It should be across the top of your screen. If you don't see it right away, click on more, and maybe it'll show up there for you.
All right, so I will go through, I will read the question and go through.
Okay, and we're up to the best approach to DC diets.
Yeah, so the best approach to dry cow diets with high potassium would be antibiotic supplements. And I think there you can go either way. Remember in the, the Western U.S. tends to have higher potassium in diets, and so they've routinely fed antibiotic diets with certainly very good success for a long time. So those certainly work. In the low potassium or the low calcium, the binder approach, you frankly probably wouldn't be worried about potassium at all. So again, you can go either way. If you feed zeolite during the dry period, don't you think there's a risk that the cow doesn't have the time or possibility to rebuild the bone calcium? And does this increase risk of milk fever in late lactation? So good question. Not to my knowledge. I would, we don't have urine, we don't really know a lot about where calcium necessarily is going there in those dry cows. I think it would be, I probably would be a little nervous feeding that binder through the entire dry period. It also comes in on a cost standpoint at, generally around $2 a cow a day is my understanding, and you're not going to want to feed it for the entire dry period for that reason either. But it's a good study. I think in general, even in some of the work that's been done in DCAD where there is some calcium drain and things like that, cows don't break down enough, or cows don't mobilize enough calcium to be truly, I would say, meaningful there. And I think the work would suggest they also rebuild during lactation. Okay, there is a difference of opinion in the field regarding the correct level of calcium in feeding DCAD. Can you comment more on your thoughts? 0.9 versus 1.2 versus greater than 1.8 is suggested by some. We're pretty comfortable in that one. If we're feeding anionic diets, we're pretty comfortable in that 1.5 calcium range. And with good intakes, that gets you into the 180 to 200 to maybe even a few more than that grams of calcium per day. Recent work out of Laura Hernandez's group, for anybody, she's at Wisconsin and kind of one of the rock stars in hypocalcemia metabolism. And Laura's group has done some work where they do actually show some better responses to higher calcium levels, kind of in the ranges that we would talk about there, and others to support that. I've generally been in the calcium supplementation camp. I recognize, though, there is tremendous diversity of practice and opinion out in the field on blood calcium. So we're still learning. On dietary calcium levels, we're still more. All right, we fed 200 grams zeolite to 3-way cross cows on a diet around 0.25% calcium, 1.5 potassium, 0.32 phos, theoretically supplying 13 grams of calcium before zeolite to milk fever prone Holstein, Jersey, Scandinavia cows, 1.7% milk fever. How low can one go with calcium? Boy, I don't know. That's a great question. We'd have to feed sticks to cows to get down to 1.25 or 0.25% calcium. So, don't know. Obviously, you had very good results there in that study. Stefano, have you some data about regulation of ionized calcium in this study? Yeah, good. We do not. So it's a good question. We've done a bunch of work on, ionized calcium gets some attention because it is the more metabolically active component of, or it's metabolically active fraction of calcium in the blood. It's also, to do it properly, it's also not only expensive to measure, but it's also very touchy in terms of sample handling and things like that. In our hands, total and ionized calcium really have given us the same results, and most of our epidemiological data that we rely on in terms of relationships to subclinical calcemia actually are built on total calcium and not on ionized. So we are comfortable with total calcium levels. Brittany Leno did do some work and published some work looking at ionized versus total calcium, just published that in Journal of Dairy Science. We do see, the dogma is that ionized is about half of the total. She does see in that cow the first couple of days post-calving or early post-calving that, or first 24 hours, I guess it was, I can't remember, but that percent, the ionized is actually more like 60% of the total. So there is some variation there. We still remain pretty comfortable with calcium. Question: when milk fever is at less than 2%, where is the metritis still coming from? Well, of course, metritis can come from a variety of different angles. Of course, there's relationships obviously with calcium. There's relationships with other aspects of immune function as related to energy status in the cow. We know that cows with lower energy intakes before calving have more metritis after calving, and poor immune function. There's some notion that may relate to protein amino acid metabolism, nutrition, other trace minerals, things like that, and vitamins, et cetera. So there's a whole bunch of other things that come into play, and I think the thing to remember is that clinical milk fever is and again, and part of me hates the analogy, but it really is the tip of the iceberg here. Okay.
All right, so that's it for our questions, and we're technically we're out of time, but we'll squeeze one more in.
I have a question. I still can't figure out how to type them. How robust is the threshold of 8.5 milligrams per deciliter for subclinical hypocalcemia? And is it do cows fall off the cliff at that point, or is there a gradual curve? I mean, hypocalcemia is somewhat normal in a high-producing cow because she takes a little while to mobilize it from her bone. So I'm just wondering, why this threshold and not another one?
Yeah, so great question. And it's an area where we're still triangulating a little bit, but I think we're getting closer. And I think that to answer you first, when these studies are done that kind of evaluate different thresholds, and what they're really doing is they're trying to get the threshold that really gives you the best level of sensitivity and specificity, essentially for that test. So trying to get the point that's really most predictive, and it doesn't mean that if she crosses that threshold that she's guaranteed to fall off the cliff. It's more about less risk and more risk for either issues with health, production, or reproduction. So that's the first thing, whether we're talking about calcium, whether we're talking about blood ketones, blood NEFAs, whatever. It's really an issue of more risk, less risk, and establishing that point. So, the studies that really got our attention in the last few years, that, one of them determined the best point within days 1 to 3 post-calving was 8.4 milligrams per, first week was 8.4. The other one was 8.6. So we kind of started triangulating in on that 8.5. The 8.0 that milligrams per deciliter has been used for years, I'm not going to say it's arbitrary, but it's pretty darn close to arbitrary, in that there was really never any epidemiological data to support that. It essentially was a best guess. If you look at some of the work that Ralph Nevis did as part of his PhD, working with Jess McCart, those actually will support it when you get out to days 2, 3, and 4 post-calving, which is where we think probably we really need to focus on subclinical hypocalcemia. It's coming in at the 8.5 or 2.125 millimolar concentration. So that stuff, Jess told me the other day, it's in revision right now. And again, those were data where they had blood samples on cows every day, so they really look at the best relationship by day. So I think we're feeling increasingly confident that that's a good place to live if you're going to pick a cut point.
Okay, Tom. So you have 2 more. If we were to blanket treat, what products do you recommend?
Yeah, I'm not gonna. So I think I'm not going to get into specific product recommendations here. But I will talk about, I think the data really say we shouldn't be blanket treating with IV calcium. Okay, I think that's pretty clear. That we should reserve those for clinical cows. The data also are not all that compelling relative to the sub-Q calcium side either. And so you are left with oral calcium. I think of those, you think about the gels and the paste and things like that. The paste tend to be kind of caustic. I don't see much of those anymore. Those are calcium chloride paste, some of them anyway. Probably the boluses are the better option for oral calcium in general. But again, our recommendation would be to try to target them as much as possible to higher risk cows. Last question I see here. In Denmark, some have argued that as long as you have a low DCAD, you can feed a lot of calcium with no problems. That's what we do, right? That's generally what we do. Yeah, okay, so another follow-up on this 8.5 milligram per deciliter thing. Follow-up on a question about threshold, probably depends on a lot of time of the testing. 8.5, not likely to stand up for testing in 12 hours. So RAF's data would say basically Ralph Nevis's data would say if you're worried about relating subclinical hypocalcemia to disease or negative effects, don't test during the first 12 hours post-calving. In fact, again, RAF had very little relationship with outcomes, very little negative relationship with outcomes the first 12 hours, and actually showed in the older cows they made more milk if they had lower calcium. Again, they weren't not clinical cows, but they're subclinical hypocalcemic. And I think the threshold there was like 1.85 or 1.9 millimolar. So that would take you down into the upper 7s for milligrams per deciliter. So I would really focus on if you're gonna think about evaluating calcium status on herds, I would not do it in the first 24 hours. I would push you out to day 2 or day 3. And I think there we have more robust or reliable, associations of negative outcomes with low calcium at those times. I think 8.5 is a good place to live.
Okay, great. Let's wind it up there. Excellent presentation. Tom, you had one more thing.
Yeah, one more thing. So I want to thank all 81 of you that joined today. I'm going to run right upstairs and tell Julio Giordano that I had 81 in my webinar and ask him how he does in his. We have a friendly competition here at Morrison Hall. So.
Hey, actually, it's a personal best. So.
Okay.
All right. Thanks very much, Tom.
Thanks
very much, Allison. This was an excellent session. So, folks, thank you for joining. Thanks for your questions. And again, if you need to review this again, we'll have the recording up. So have a great afternoon, evening, whatever, like Tom said, wherever you are at today. Take care.
Thank you, Catherine. Thank you, Tom.
Thanks, everybody.